You're live.
Welcome to Ortho TV Online and Navi Mumbai Orthopedic Association webinar series. We hand over to Dr. Sanjay Dar to take over the proceeding. Today's topic is wrist injuries.
Good evening in India and good evening Navi Mumbai in Mumbai, and good morning to David Nelson. Dr. David Nelson is our guest faculty today. He's I should call a wrist surgeon in San Francisco Bay Area. He's an avid writer, avid climber, avid, and we had the good fortune of seeing him operate in last year in Navi Mumbai when he came as a guest faculty for our conference in MedInspire 2019. Besides his work in distal radius and hand, I found him a very interesting person and always a pleasure to talk to. So I thought, and as far as orthopedics and wrist is concerned, he sort of changed our so many concepts in a very brief meeting we had with him. So I thought it's better to share all that with you all. And since we have the good fortune of having online webinars these days, so the access and reach is all over the country. So I thought this is the best time to introduce him to the rest of the country. Being early morning in San Francisco, it was great of him to get up so early and come to his laptop in the morning. So I welcome Dr. David Nelson from San Francisco, and I'm sure you'll be impressed with his thought process as far as distal radius is concerned. We have also with us Dr. Pankaj Ahire, my junior colleague, my student. In fact, now I learn lots of things about distal radius and hand from him. Now a very close friend also. He has confined himself to hand and lower upper extremity, wrist and elbow, wrist only. So we have the good fortune of having him also today, and he will be also talking about certain aspects of wrist pathology. And besides Pankaj, we have Dr. Prasad Chaudhary, who is again my ex-student, but now my colleague. He's a faculty with me in Dr. D.Y. Patil Hospital. He's a professor there. And all this, he will be sort of running the show more or less, and he will be showing some cases, and we'll be all discussing that with our faculty, Dr. Nelson and Dr. Pankaj. And all this, the credit goes to Dr. Neeraj Bijlani, who as always is forcing us out of our slumbers during this COVID times and forcing us to do all these webinars. And thanks to COVID, we have learned so much of digital technology and this digital learning. I'm sure one thing which is going to stay after COVID is this digital platform which we have got. Thank you very much, Neeraj. And I hand it over to Dr. Prasad if he wants to continue and start.
Yeah. Good morning, all of you. Good morning, Dr. Nelson, and good evening to the fellow Indians. I would now invite Dr. Nelson to start his presentation on distal and radius fractures.
All right. Well, thank you to everyone. It's a pleasure to be here. And I'm going to be speaking on distal radius fractures. Let's get this going here. There we go. Okay. I think it's appropriate first, though, to acknowledge that the COVID virus is afflicting the entire world. India is certainly having a very tough time of it. And we should acknowledge the hard work of all our associates who are taking care of COVID patients. And it makes you proud to be a doctor at this time when so many of your colleagues are working so hard to save lives. I'm going to be talking about complications of the volar approach to distal radius fractures and anatomic and engineering analysis. My original training was as an engineer. I used to work in engineering, And that has helped inform my approach to how I understand distal radius fractures and how to take care of them. So, this is the ulnar view of a distal radius. And this is the X-ray of that. On the left side, I've removed the ulnar styloid. And I want to make the point that the purpose of the wrist is to hold the hand in the air. That's all it does. The purpose of the forearm is to position the hand. And the red arrow shows where that force is. And it's here. So the subchondral bone is the single most important part of the radius. And you can see here, this is a micro CT cut through a radius. And what this is, the thickest bone is the subchondral bone. It's a lot thicker than the volar cortex, and the thinnest of all is the dorsal cortex. So my point is that the thick subchondral bone is what supports the hand in the air. I believe Margaret McQueen of Edinburgh was the first one who taught this to me, and it forms the entire basis for the volar approach to the distal radius. It's subchondral support. Okay, now, Orbe and Fernandez first described this in 2000 in this report. All new techniques bring new complications, and unfortunately, this approach is no different than any other. It has its own complications. Now, this approach is only going to cover a few of the complications. A full paper is online at this, and I'll give you the URL later, but it's on eradius.com, which is a website I own. It is non-commercial. It's purely academic. There are no advertisements on it, and I don't make any money from it. So this is eRadius. All right, so what's the basis for this presentation? There are my own cases, but also the cases of Dr. George Orbe, who designed the very first volar plate, and Randy Bindra, who's a brilliant surgeon originally from India, then for a while in England, then the United States. He's now in Australia. We did 14 cadaveric dissections. Some of them were done individually, but several we did all together, all three of us. And then we studied 39 prepare radii, which are in my personal collection. And here are the three of us. I'm in front, George Orbe in the middle, and Randy Bindra in the back, in 2006, when we're doing our joint dissections of radii in order to come up with the concepts I have here today. The very first complication that was reported was dorsal tendon injury. Not only was the first complication, it was reported by Orbe in the very first paper. He had one case of it. This is his X-ray from that paper. And if you and I were to look at that, we'd say that the distal screws are actually pretty good. They are well within the bone. How did they possibly irritate a tendon? They look good. Well, let's look at it. A little engineering and a review of anatomy explains the problem. Here's a cross-sectional view of a radius. You recognize that. And the PA and lateral X-ray presumes that the radius is rectangular. Well, we can see here the radius is not at all rectangular. It's not rectangular. The dorsal cortex is dihedral. And when you take a lateral X-ray, in a sense, you're fooling yourself. Well, let's put on a plate and let's put on some screws. Now, all of these screws we can see are in the tendons. Let's take a lateral X-ray. They're all sticking into the tendons, and I call this particular screw the posterior interosseous nerve fixation screw. Now, here's our lateral X-ray, and if we did this, every single screw tip do not extend beyond Lister's tubercle. It's going to look like it's within the bone. So the X-ray on a lateral makes them appear that they do not extend beyond the bone, but obviously they do. All right. Now, let's move this line down. Even if we don't use Lister's tubercle as the dorsal cortex, none of these screws will appear to extend beyond the bone, but every single one of them are into the tendons. That's a disaster. Now, here's my own clinical case. This was a very early case of mine. This is probably a little more than 15 years ago. And when you get a complication, don't make it the mother-in-law of an orthopedic chairman who offered you your first job, but that's what I did here. And I took photographs of the x-rays and I sent them to the orthopedic chairman, and he and I were both very happy with these x-rays. We thought I did a great job. And the screw placement seemed good. However, she kept complaining of pain. And the question is that outside the bone or not? That looks like it's inside the bone. Well, we did a CT scan, and every single screw was out into the tendons. It wasn't just one, every single screw was out in the tendons. Now, how did I do that? Just that is enough to put every screw into the tendons. Now, let's look at that closely. If you and I were to do that, it looks like it's inside the bone. That's not the ulna that's hiding the tips, that's the radius. Well, here's a different case. I did a volar approach to radius. Subsequent to that, the patient developed a dorsal ganglion. And I went down to look at the dorsal ganglion, and this is what I saw. And I was appalled. Those are shredded tendons. That's not a ganglion. Those are shredded extensor tendons. Why? Well, it was a single screw tip. Let's look. I've moved the tendons out of the way, and you see that little dot. Let's look at it closer. It's only a millimeter beyond the bone, and yet that one screw tip caused all that shredded tendons. All right. Now, what's going on? Why is so little passporting a problem? It's only a millimeter too long. And it caused all of that problem. We can never be as little as a millimeter too long. But why? Anatomy always gives us the explanation. Here's a cross-section of the distal radius. Let's blow up the dorsal part of it a little bit. And if you look at that, there's the tendon. The tendons are in apposition to the bone. There is no space for passporting, absolutely none. You cannot be even a fraction of a millimeter too long. There's no space for passporting. So what's a surgeon to do? Well, we ask, why are we trying to make the pin so long? And I like to blame it on AO just for fun, because they taught us bicortical purchase, correct? We always aspire for bicortical purchase. So let's take a radius and stick a screw in there. And what's bicortical purchase mean? Well, it means we want to grab both the volar and the dorsal cortex when our screw. If we don't do that, we don't have good purchase. All right. Now, let's put on a radius plate. There we go. And now let's look at the distal screw. Where's the proximal cortex? Well, the proximal cortex is the plate. We don't engage the bone at all. I mean, it screws into the plate. So the proximal cortex is the plate. But what about the distal cortex? What's the distal cortex? It's the subchondral bone. Remember, I started this out saying the subchondral bone is the most, or the strongest part of the radius, and the whole concept of volar plating is subchondral support. If we support the subchondral bone of the lunate and scaphoid facet, we support the radius, the wrist, and we don't need to support anymore. So the distal cortex is the subchondral bone. There's no need, and in fact, there's considerable danger in engaging the dorsal cortex, as we saw just a moment ago from that anatomy slide. So I just want to emphasize, there is no need, and indeed there's considerable danger in engaging the dorsal cortex. So how do we determine the right screw length? Let me show you that. I'd like to give you a new term. I call it the dorsal subchondral support line. Okay, here's the radius, and we can see the subchondral bone. Now notice where it ends dorsally. It stops here. Any bone to the left of this does not support the lunate and the scaphoid facet, and they do not support the hand. So any bone to the left of this line, which I call the dorsal subchondral support line, does not do any subchondral support. You never want your screw beyond this red line. Never here. Because it doesn't support the hand, it doesn't support the subchondral bone, And all you're going to do is get into trouble with the tendons. None of this bone supports the carpus. So your screw shouldn't be here. Any screw that goes beyond the line is causing a problem. The tip does not support the carpus. It's just out there. The tip should be there, because now you completely support the subchondral bone, and this supports the wrist. You could actually be a few millimeters short, and you'd probably do fine. It fully supports the carpus. Okay, let's look at a clinical case. So we could see this distal radius fracture. And here's a plate. This is not my case. And this looks pretty good, right? But here's the dorsal subchondral support line. Those screws are all beyond the subchondral support line. They're not doing anything to support the hand, and all they do is risk going into tendons. And here's an end view of the radius. And this is the dorsal subchondral support line. This is the edge of the lunate and scaphoid facet. Any bone dorsal to this doesn't support the carpus. So to review, the lateral X-ray is incapable of detecting past pointing. A little as 1 millimeter can be dangerous. The dorsal cortex really is the subchondral bone. So there's no need to engage the dorsal cortex. So my goal is that. The next complication that we saw with volar plating is intra-articular screw placement. So here's a lateral view. And of course, we know that that screw's not in the lunate. It looks like it is, but if we take a facet view and tilt the radius, when we look at the X-ray, we can see that screw is just into the radial styloid. There's nothing in the joint. So facet horizon. This is a term from Rob Medoff of Hawaii, who invented the fragment-specific approach. So carpal facet horizon is a very good term. But the facet view is not one specific view. It's been written in the literature that it is, but it's not. Let's look at that. The facet views are actually an infinite number of views. It depends what you want to look at. So for instance, on a true PA, this is a facet view that looks at that part of the facet, but the facet is curved. This facet view looks at this bone, and this facet view looks at this bone. So you need to tilt the radius and look at the part of the subchondral bone that you're interested in. All of these are facet views, and each demonstrates a different part of the articular facet. So here's a facet view, and it looks at that part of the bone. But that's not really very interesting. That's the joint between the scaphoid and the lunate. This looks at the weight-bearing portion of the scaphoid facet, and this looks at the weight-bearing portion of the lunate facet. So all of these are possible views. It's not just one view. But how do you get it? Well, you just tilt it. Now, in the operating room, you tilt the C-arm or you tilt the radius. But we often forget to take facet views in the office. What we do is we say, take a PA and lateral. That's the way we were trained. So doctors don't have a learning disability. They have an unlearning disability, because you should not get a PA and lateral. Here's an arm. If you just prop it up on a roll of web roll, that will give you a very nice lateral facet. And if you do the same thing with a PA, you'll get a very nice PA facet view. And they're just one facet view of each direction, but they will show you where the screws are much better than if you order a PA and lateral. So a roll of cast padding under the wrist is a great way to get a very nice facet lateral, facet PA. Now, I'd like to show you some anatomy findings from our anatomy study. As I told you, we did a lot of cadavers. So volar tendon injury is also a problem, and we understand it when we understand anatomy. So this is a radius looking at the volar aspect, and in this case, I have the light coming from above, which then throws a shadow and magnifies this area here, which is where the pronator quadratus is. Now, this is a line we've all heard of. This is the watershed line. Dr. George Orbe of Florida in the United States came up with this term, and he approved this slide that this is the watershed line. Now, the watershed line is the highest margin of the distal radius. So right here on a lateral, that would be the watershed line at that level, okay? And it's what's going to be closest to the volar tendons. So if the tendon is touching a plate here, it could be a problem. So here's a plate. We don't want it up here. Up here, the tendon will be bearing on the plate, and honestly, titanium or stainless is not a good bearing surface for a flexor tendon. It causes problems, as we probably all have seen. So right here, this is the lunate facet. But what would you call the bone here? There's no term for it, so we just decided to call it the lunate facet buttress. It's the volar cortex that supports the lunate facet, and it sticks out a fair amount. In studies that I've done, it could stick up quite a bit. This is the same radius, absolutely the same bone, but now the light's coming from the radial side, okay? And I want to show you this here is the volar radial tuberosity. It's a piece of bone, and you can feel it in your own wrist. It's probably worthwhile doing it. If you palpate the volar aspect of your wrist, where the scaphoid tuberosity is, and then just go proximal. Can you feel in your own wrist there's a point of bone there? That's the volar radial tuberosity. And then the volar radial ridge is this. This particular bone is most likely from a female cadaver. And the ridge is larger in some people than in others, but you have to be aware of it. And here is a lateral view of a radius. Here is the volar cortex. This is the lunate facet buttress. You've seen this line many times before, right? When you look at the lateral of a radius, there's the volar cortex. But right here, that's the volar radial ridge. It's been in every x-ray you've ever seen. You just don't recognize it. But that's the volar radial ridge, because there it goes all the way up to the radial styloid. You see that? Okay. So volar radial ridge. Now, let's review. Watershed line, volar radial tuberosity, volar radial ridge, and the lunate facet buttress. Now, why are these relevant? Well, the plate should never extend beyond the watershed line. Whenever you extend to or beyond the watershed line, you risk contacting the tendons. So you want to avoid that. Now, the lunate facet buttress, if it's prominent, may require a pre-contoured plate. A totally flat plate will get lifted up here and make this more prominent. So the plate that you use either needs to be pre-contoured or have the capability of you contouring it. This is most, I find, in strong men, that the lunate facet buttress can be rather tall. Now, if the volar radial ridge is large, and in my studies in cadavers, I've found it could be between 2 and 8 millimeters tall, you have to be careful. Don't let your plate drift too far radially. If it does, it will hit the volar radial tuberosity and the volar radial ridge. It'll lift up the radial side of the plate, and then it'll be palpable to the patient on the volar radial aspect of the wrist. And I did have one plate I had to remove. It was a woman who was quite tall, but very thin. The plate was too far radial, and she could feel it, and I had to take the plate out. So care must be taken to not either place it too radially or be sure to contour the plate. And always check for your plate placement prior to accepting it. So place the plate, hold it with a K-wire, and then take the retractors out and feel how prominent is the plate on the radial aspect of the wrist. Would you like to find out now, not in the clinic? Okay. Now, several causes of volar tendon injury. First of all, it's volar plates. Here's a plate that was a poorly designed plate. It always had to go up over the watershed line, and that part of the plate caused a problem. And it was worse because of the angle of the holes through the plate created a cutting edge on the distal margin of the hole. And here's a case where you can see the plate is sticking up on that side and caused tendon injury. Well, luckily, it was not my case. Now, incomplete reduction can also cause volar tendon injury, and this is my case. This is probably 25 years ago. This was a volar pie plate made by Synthes, and you can see on the lateral, I did not reduce the fracture. It's in dorsal tilt. Well, if you've got a pre-contoured plate and you do not reduce the fracture, can we move this out of the way? Yeah, there we go. You can see because the fracture is not reduced, it doesn't fit the plate, and therefore the plate's prominent. So you have to reduce the plate. Or I'm sorry, the fracture, reduce the fracture. So incomplete reduction will do it, and that's a problem. Okay. And here is the plate. It was 9 years after I placed it. It was in a school bus driver. She ruptured FPL from the plate that was sticking up in the road through the capsule. This is my case. So improper plate placement, as we've discussed, if it's too far distally or too far radially, or backing out of the distal screws. You want to make sure before you leave the OR that each screw is locked down so it can't back out. All right. What about the dorsal ulnar fragment of the radius? This is a typical fracture, and we can see that there's a fracture going across the radius. You can see it here, fracture line here, and we can see here the fracture. All right, so this is not my case. The doctor placed a volar plate. We don't need to fix the ulnar styloid unless there's DRUJ instability. But let's look at the radius plate. Did we do a good job, or did the doctor do a good job? When a screw comes this far radially, you're in high danger of this sticking out. Fluoroscopic views are really needed. But other than that, did we fix the fracture, or did that doctor fix the fracture? The patient was complaining of pain with pronation, supination. And we look over here, we say, well, you know, there is this vertical fracture line and that, but what do we really see? If you take an oblique, now you can really tell it. It's very important to take an oblique. This is not just a small marginal fracture. This is a large piece of the dorsal ulnar cortex, and that needs further stabilization. And what I do in the operating room is, after I fix the fracture, I try to sublux the carpus dorsally or volarly. And if I cannot move it with some force, it's not going to drift out later. But if when you push dorsally, the radius, the carpus moves dorsally, means you have to come around and put a plate on the dorsal side. So this can get you. Those two are actually part of the same fragment. You really can't see it on the PA view. You need an oblique view. So after the open reduction intrafixation, test the DRUJ in the OR by trying to translocate the carpus dorsally or volarly. And if you need to, go around to the dorsal side and add a dorsal plate to stabilize that. So unstable volar lunate fragment. This has been written up. George Orbe actually has written a paper on this. You can have a very small fragment of the volar lip of the lunate facet. So here's a case of mine, and you can see it's a very distal fracture. And here's the fracture line. And I placed a plate, but you notice the screws may catch the dorsal aspect, but it's not buttressing the volar aspect. The fragment is not stabilized. So what do? You don't want to put the plate out more distally. If you do, you've crossed the watershed line. You'll have to take the plate out. I don't want to have to do that. So what do? Well, it's fairly easy. If this is the volar fragment on a lateral view, If you could only put a K-wire in it, that would stabilize it, wouldn't it? So what you do, let me move this over, is you place it too far, then pull it back, bend it so it fits the profile of the radius, push it back. You've already drilled the hole, so it'll easily go back, and then just put the plate on top of it. Or you could put a screw through a hole, which I did here. So that K-wire totally stabilizes the fragment. And although there are volar hooks that you can use and other things, you may not have that in your set, may not be in the operating room. You'll always have a K-wire. And you can always just place a K-wire and then contour it and either put the plate on top of it or hold it with a screw. But this amount of metal will not cause a problem to your volar tendons. If you put the plate up here and buttress the fragment, that would. Okay, those screws hold it. And if you want, on the website eRadius, right here under basic knowledge, there's an essay I wrote with pictures with many more of the complications of volar plating. So that's the URL, eradius.com, complicationspaper.htm. It is not a commercial site. I don't make any money from it. There are no ads. It's just for teaching surgeons about radius complications. And that's my talk. Thank you very much. And stop share. There you go.
Thank you, Dr. Nelson. That was an excellent presentation. I have to ask you, I mean, there are many people who do not know about TFZ. So I would like you to talk about some transitional fibrous zone that we usually encounter while we're plating. Yeah.
Right. There's further information on that website. The question comes, can you cover the distal margin of the plate with soft tissue? I didn't cover this topic in the talk, and that's an important question. We would like to cover the plate with soft tissue, but can you? Is the pronator quadratus adequate, or what about the tissue distal to it? So Dr. Orbe and Dr. Binder and I did some experiments, and we took the position that if you could dissect soft tissue and it didn't move with wrist flexion and extension, it was not a volar ligament, it was tissue that was stuck to the radius. And what we did is we found that you could dissect 2 millimeters distal to the pronator quadratus, and you would not be into the volar wrist ligaments, and you could use that tissue to cover the plate. So let me say that again. Obviously, when you're doing surgery, you plan your closure as you make your incision, right? If you don't, you could dissect yourself into a position you can't get out of. So you do a volar approach, you come down, you're looking at the pronator quadratus, and you're wondering where to dissect it. If you dissect it about 2 millimeters distal to the muscle fibers of the pronator quadratus, and then continue that over radially, and you could go just a millimeter beyond the bone into the first extensive compartment, and make that your dissection to mobilize the pronator quadratus. What you do is you'll leave a rim of fibrous tissue on the pronator quadratus, because we've all had the experience. You release the pronator quadratus, and as you try to close it, every stitch just comes right out of that little thin fascia. It's I like to call it suturing flatus to moonbeam. Thank you. And if you leave a little rim of fibrous tissue when you dissect the pronator quadratus, that tissue will be firmly bound to the muscle fibers, and when you suture it, it will stay in place. So don't cut into the muscle fibers. You can cut 2 millimeters distal the muscle fibers. That's not the volar wrist ligaments, and you'll be able to close the plate with the pronator quadratus, and that should keep tendons out of the plate, even if you threaten the watershed line just a little bit. That was a very good question. In your own cases, have you found that that's possible?
Yeah, in most of my cases, I find that the pronator quadrate is a bit flimsy, and the volar beak of the proximal fragment usually tears the pronator quadratus, and I have difficulty getting it back.
And you don't have to actually repair that part of the pronator quadratus because that's so far away from the distal edge of the plate, it's not prominent. So even when the pronator quadratus is shredded by the fracture, and it often is, what you want to do is, as you make your dissection, and you have to get your release of the flexure carpi radialis done distally enough to see this part of the bone. And if you're struggling with exposure, almost always it's you did not release the superficial and deep sheath of the flexor carpi radialis long enough. I'm not aware of it being possible to go too long. So if you're struggling, just release some more of that. Get a good visualization of the pronator quadratus and the volar capsule, and then incise the pronator quadratus 2 millimeters distal. Even if it's shredded in the mid part, you don't care. What you want to do is you want to cover the distal part of the plate, and that piece of tissue is always intact because the radius doesn't break at that level. It breaks down below the subcondylar bone. I hope that's clear.
Yes. There's one more question. I mean, in some instances, post-operatively, I had FPL adhesions to the plate. So is there any experience about yourself about having FPL adhesions to the plate, or the thumb not getting completely extended sometimes?
Yeah, I've not really had that problem, or if I have, I've not recognized it. It's an exceedingly rare case that I cannot completely cover the plate. And if you're using a plate that's properly polished, properly rounded, you stay proximal to the watershed line, and you cover it with the pronator quadratus. Honestly, I've not had that problem. When I've had ruptured FPL, it's been either I didn't reduce the fracture as that case, or I'm doing a case done elsewhere, because I don't think in 15 years I've ruptured an FPL. Maybe I've just been lucky.
Yes, sir. Thank you so much. Pankaj, would you like to ask any questions? Pankaj or sir?
No, it was a very enlightening talk. Part of it I'd heard before from you, and it made even better impact when I heard it again. It was so wonderful, and it just makes us wonder whether we look at the X-rays hard enough, and we do get carried away by getting CT scans and MRIs. More and more microscopic views, and we are losing the macroscopic view. There's X-rays talk a lot. We just have to listen hard enough.
That's right. I think if you look at your mentors who you really respect, they can read so much more out of the plain film than we do when we just take a cursory look. And it's worth looking at it very hard. Don't be cursory. There's lots of information there. I find that I get very few CT scans of a distal radius. A plain film will always underrepresent the fracture, and a CT scan will always overrepresent the fracture. I rarely get a CT scan. I think I can read the plain film, and even when it's highly comminuted, what I'm going to do is use the carpus as a template, push the fragments up against that template, then support everything with a proper volar plate.
Right. Hello,
sir.
Yeah. David, thank you very much for a very enlightening talk, although I had a lot of interaction on this last time also, but always learning is, listening to you is always a learning experience. I just wanted to know, because usually you have, even if you have restored the facets quite well, many times your radial the styloid, and there is dorsolateral comminution, which doesn't sit properly, and you keep on fiddling with that and getting that into the bony architecture, restoring it. So how do you manage that?
Okay, let me make sure I understand the case that you're
In fact, we
presenting.
spend a lot of time getting that into position, either with a screw or, as you said, that K-wire technique, K-wire in the styloid, and then
Okay,
try
but
to
are
hold
you
it.
talking about subchondral bone, or you talk about the
So
cortex?
there's a large styloid fragment and the dorsolateral comminution while you are opening and opening.
Yeah. I have put on a few radial sided plates, but very, very few.
Yeah.
The radial styloid does not really support the scaphoid facet. It's quite a far distance over. And I would not worry about cortex that was outside the subchondral bone. And if you have any doubt about, is this fragment something you need to fix, while you're under fluoroscopy, grab the hand with one hand and the shaft with the other, and try to dislocate or sublux the carpus in that direction. If it doesn't, I think you don't need to go fix that.
So
So I
that's
would
why
not spend a lot
as
of
you
time.
said, if the scaphoid facet is restored, can you leave the radial styloid alone? We have been doing it many times inadvertently because we could not fix it. So finally, we leave it alone. But luckily, we are not.
If you try to force the radius, I mean the carpus radially, and that little fragment opens up, it means it probably needs to be stabilized. But if it's fragments that don't open up, it probably doesn't need to be stabilized. Did that
Yes.
answer your question, Professor?
Yeah.
Okay.
Sir, he's asking you whether you have any more questions, sir.
I thought then you can show the X-rays.
No, I think now I think I'll invite Dr. Pankaj now for his talk
Okay,
on DRUJ. After that, then maybe we can discuss a few more cases.
Hi,
Pankaj, over to you. Yeah.
good evening and good morning, Professor. I'm going to restrict my talk to the DRUJ. So that's where I am. So I'm going to focus my talk on DRUJ, and a painful DRUJ could present in various forms, either as a pure dislocation, very minor discrepancies of alignment, an overtly arthritic joint, a malunited distal ulna scalloping into the DRUJ, and obviously dislocated or dorsally dislocated. It has various forms. So obviously, depending on the presentation, we need to tailor our treatment. There is no one treatment that fits all approach that can be taken here. So when do I address the DRUJ? If I have to talk about the traumatic problems affecting the DRUJ, well, it's only occasionally that I need to DRUJ, but I look for it always. And how do I look for it? One, a very careful look at the X-ray, intraoperative fluoroscopy. If you can see this spike, this is going to be an issue if left unattended. And after I have fixed my distal radius, I always ballot the ulna and check for DRUJ instability. This is an obviously unstable DRUJ. And if I do find an incongruity or an instability, I know I must address it. A very simple way of addressing this incongruity is first identifying it. Then a very simple trick is to insinuate a K-wire on the radial border of the plate and use this K-wire to push the plate with the distal fragment ulnarwards and the shaft radialward, thereby making this step disappear. Once you have achieved this, while retaining this plate, you put another thin K-wire through the plate so that now this alignment is maintained. This is a simple trick which I use very often, and you can see that the spike in the distal radioulnar joint is gone. Many a times a very small step, an articular step in this area can be a source of great discomfort in forearm pronations in an otherwise well-fixed distal radius fracture. When it comes to instability, okay, I'll just take you through a few examples. a comminuted distal radius fracture, only a tiny styloid fragment. Did not expect the DRUJ to be very unstable, because as we know, it's the foveal fractures which are more likely to be representative of significant TFCC injury. After I fixed the distal radius to my satisfaction, and as Dr. Nelson showed, I was not very happy with the fixation of the volar lunate fragment. So I put an additional screw distal to the plate to ensure that I engaged it. So at the end of the fixation, this is what I had. And so I proceeded to did an open repair of the TFCC. And then it was found to be stable. I always do it, not the fixation, but check. If I'm in doubt, I would go over to the unscrubbed side, unprepped side, check the opposite side of the patient, and come back, remove my gloves and come back, just to be very sure that what I'm dealing with is not a simple hyperlax joint, but actual traumatic instability. So if I have just a styloid tip fracture, but the DRUJ is unstable after radius fixation, I would want to repair the TFCC. Fixation of the styloid itself is just it's a template for fixation of the TFCC. So coming back to the same case, this is what was done. As you can see, the styloid has fallen back, but that was not the aim really. You can see these holes of figure of 8 that has been ethibond figure of 8 that has been passed to the TFCC, and the styloid simply acts as a template. This gives a very stable DRUJ. If you have a fracture which runs through the base of the styloid, this is very likely to carry the TFCC with it. And if this fragment falls back after your radius fixation, you can safely assume that the TFCC has fallen back in place. And then you have a choice of immobilizing this forearm for 6 weeks till the fracture heals. And if you do not want to extend the period of immobilization for 6 weeks, then you can actually go ahead and fix this. So this is another example of a styloid fracture to the base. And that's how it is. And I fixed it using a headless compression screw because I did not want to immobilize for 6 weeks. Remember, if the fracture did not fall back in place after fixation of the radius, then it mandates that you need to repair this, especially if you check for the TFCC DRUJ instability and find that it is unstable, then you can assume that there's a TFCC tear. So this is another example. One was a headless compression screw. You could also fix it using tension band traction absorption system. Key thing is there is no role of percutaneous fixation. It's always open. Fix it nicely. Avoid damage to the dorsal sensory branch of the ulnar nerve. I have seen complications of impingement and injury to the dorsal sensory branch of the ulnar nerve in attempted percutaneous fixations of the ulnar styloid. So I'm far happier opening it wide and then fixing it. So you have a ulnar styloid fracture through the fovea. If it remains undisplaced or falls back, you can immobilize it for 6 weeks. If it remains displaced, you fix. So if you have a DRUJ that is unstable, but there is no ulnar styloid fracture at all, it means there is a TFCC tear and this TFCC requires a repair. So when you have a TFCC injury, it can present in various forms. It can be associated with the distal radius fracture, or it can be without the distal radius fracture. You can have a stable DRUJ and unstable DRUJ. Key thing is, if the TFCC is repairable, you need to repair it. And if it's not repaired, you'll need to reconstruct it. So if you have an isolated TFCC tear, the foveal attachment may still be intact. The DRUJ is stable. However, it may still produce pain, and a simple above elbow cast may suffice. If you have a foveal detachment, like what is shown in this picture, the DRUJ will be unstable. There may be pain as well, and this is what requires a repair. So this is an example of an unstable DRUJ with isolated TFCC injury. There's no distal radius injury. And then this was subjected to arthroscopic examination, and we did an arthroscopic repair for this. I'll just cut short this video. So that's the arthroscopic stitch. This was a capsuloligamentous repair. This was not a foveal repair. A foveal repair is much ideal, much stable. Capsuloligamentous repair can still give you a reasonably stable DRUJ and may reduce pain and synovitis. This was done at a time when I was not very proficient with arthroscopic TFCC repairs. As you can see, this is a diagnostic scopy done, and then I decided this is another patient in whom I decided to do an open TFCC repair. So I'll just take you through a few key steps. So that's where the TFCC is, and that's the TFCC fovea which is getting cleared, and there is an anchor that is placed in the fovea. That's the anchor placed in the fovea, and the TFCC is repaired. And in the end, the capsule of the dorsal capsule of the distal radioulnar joint is also repaired, and the repair of the extensor retinaculum gives us the final stability of the DRUJ. So this is one way of doing an open repair. That's the extensor retinaculum. Now I'm much happier doing an arthroscopic repair of the TFCC into the fovea. So just take you through the traumatic TFCC tear. You have an ulnar styloid tip fracture. If the DRUJ is unstable after radius fixation, you need to repair the TFCC. Styloid simply acts as a guide. If you have an ulnar styloid fractured through the fovea, and the styloid falls back after DER fixation, then you can immobilize or fix the ulnar styloid. If the styloid remains displaced, you're much better off fixing it with whichever method you want, but it should necessarily be an open repair. TFCC tear without the ulnar styloid fracture, you must repair the TFCC either arthroscopic or open. So this just allow me to introduce a very nice algorithm developed by Sanchpecker from Mayo and Mark Garcia Elias from Spain. It's called the four-leaf clover algorithm for management of the DRUJ. So far, what we have saw in the presentation was about the traumatic aspects of the DRUJ and focused on TFCC. There are a whole lot of other pathologies in the DRUJ which make it painful or unstable. So the four leaves of this clover are: one, whether the ECU is unstable or not, which is a great contributor to the pain on the ulnar side and is part of your TFCC construct. Then, is the TFCC itself is affected or not? How is the articular cartilage of the DRUJ? Or is there any bony deformity which is contributing to the problem? If you try and answer these questions in each of the DRUJ pathology you have, then you will know exactly what is to be done in each case. Problem is, these will not exist in isolation. So you do not have 4 patterns of problems in DRUJ, but what you have is a mix of them. So you have virtually 13 different permutations and combinations that are possible, far bigger, far more than 13 actually. So let's take a few examples. This was the example that I talked to you about. If you were to if you were to apply the algorithm to this, so you would say, yes, this only has a TFCC tear and there are no other problems. So I would do either open and arthroscopic TFCC repair. Remember, the literature says no significant difference between open repair and arthroscopic repair. So don't fret if you cannot do an arthroscopic TFCC repair. Open repair works as well. So if you have a DRUJ incongruity, again, where does the problem lie? The problem lies in the bony deformity. This will not be addressed by any other method. So we address the bony deformity by doing the maneuver that I showed you in the video earlier, and we address this problem. Take this example of a volar dislocation of this was about 2 months since injury. Very rare presentation of a isolated volar dislocation. So this patient obviously had a TFCC tear. in 2 months, you do not expect the DRUJ to get eroded, the cartilage to get eroded. Obviously, on MRI, the cartilage was intact. There was no obvious bony fracture or deformity. The ECU was in its place. So all I needed to do this to ensure that once the bony alignment is taken care of, I just need to repair the TFCC, and that's exactly what we did. Through Volar approach, we opened this joint, reduced, and fixed the TFCC, and this went on to do very well. Take another example of a dorsal dislocation. Here, the problem is compounded by some other injury. You can see the distal radius that is fractured and malunited. So the problem here is not only restricted to the TFCC, but there is a bony deformity as well. Now, this was a presentation almost 1.5 years after injury, and the TFCC was completely degenerated and not repairable. So what we did in this case was we did a corrective osteotomy of the radius, and we did a reconstruction, Adamberger reconstruction of the TFCC. Unfortunately, I cannot present pictures of this patient, but I can tell you that this patient got rid of the symptoms that she presented with and went on to do very well. She presented with a very painful clunk, which got addressed by doing this. This is another case which had a malunited distal radius with erosion of the cartilage, and this was the only rotation that he had, and it was painful. And it was a stable DRUJ. Mind you, the TFCC appeared healthy. Perhaps a very negative ulnar variance saved the TFCC. So what we did for this patient, okay, we applied the algorithm. So this was the cartilage defect that was a problem. So we had to address the cartilage defect somehow. I'll just switch off my video because my connection may be unstable. Okay, I'll just switch off my video. My presentation will continue to run. Okay, so there was a cartilage defect. The TFCC was good, the ECU was good. There was a bony deformity of the radius, but once we address this cartilage defect by excision, then this need not be, with this we thought need not be addressed. So we excised the DRUJ, the radial half of the ulna, and put a palmaris longus interposition in that area. That was how the excision was done through the volar approach. And intraoperatively, we could restore the rotation to near normal. This was another case, again, distal radius fixed, the DRUJ not addressed, presented almost a year after injury, restricted range of movement, a prominent ulna. The CT scan showed that the ulna was completely deformed and the articular cartilage was completely eroded. So this is what was done. There was no TFCC. So there was a TFCC tear as well. The MRI did show a TFCC tear as well. So it was an unstable and a painful DRUJ. There was a bony deformity. There was a cartilage defect. So the most effective way of addressing this, we thought, was either a replacement or an excision arthroplasty. This was a very young patient. He was, I think, a 20-year-old boy. We have no access to DRUJ replacement in any form in India yet. So this is what we did. Dara's distal ulnar excision, and I always try and stabilize the stump with the ECU sling. And this boy went on to do very well, got rid of his symptoms. Other option would have been a Sovacopanji procedure. I have never done a Sovacopanji procedure, so my experience is limited to reading from the literature. The literature does say, though, that there's no difference in the functional outcome or reoperation rate between a Sovacopanji or a Dara procedure. This was another lady. She was approximately, I think, 68, 70 years old. She was a known case of rheumatoid arthritis on DMARDs, came with a painful wrist with swelling, which was persisting for a few months. This was the X-ray, a joint completely destroyed, very painful. Carpus seemed to be subluxating. This was her MRI. That is the radius and the ulna, and all these brownish thing that I made it brown. It's all the synovium and the hypertrophic soft tissues around the radius and the ulna. So this patient also had severe ECU subluxation. So she had TFCC, which was completely destroyed. There was a bony deformity, cartilage was completely gone. The ECU was completely subluxated. So this is what was done for this patient. There is no other way I could have addressed this. This eventually histopathologically turned out to be tuberculosis. She was put on anti-tubercular treatment and went on to heal very well. Before she had good recovery, she fractured at the end of the plate, and then we had to revise it with using a longer plate. So, but then her pathology healed. This is another young patient, distal radius fracture treated conservatively, continued to complain of pain on the ulnar side. And this was his normal side. You can see the ulnar variance here and a positive ulnar variance here. The radius seemed to be aligned pretty well. So this is what he had. So there was only a bony deformity. He also had a very unstable TFCC. And so the cartilage was normal. So what we decided was repair the TFCC. That's the TFCC tear you can see. So we repaired the TFCC and did ulnar shortening. And this is what we could achieve, the repair of the TFCC and ulnar shortening. We did this almost beyond 8 months after injury, and I forced myself to put a wire. I think this is the only case in which I have put a radius ulnar wire in over 15 years. So if you have overt arthritis of the DRUJ, these are the 3 options that exist for us. One, either we excise DARA procedure, or we fuse and create a pseudoarthrosis. This is a textbook image, Sovekapanji. Or we do an interposition. This is the same patient whose video I showed some time ago. So irrespective of the procedure that we do, the problem that remains with this type of treatment for DRUJ is the impingement of the ulnar stump. So we ought to remember that DRUJ does bear significant load when the forearms is loaded, and that is what brings the ulnar onto the radius, and the stump problems start happening. We need to somehow address this, and the most effective way of addressing as on today seems to be either a hemi replacement or a total replacement of the ulna or the total replacement of the DRUJ. None of these are actually available in India at the moment, and we are aware that the shaker prosthesis, the DRUJ prosthesis, is prohibitively expensive at the moment. So just to summarize, DRUJ causing ulnar-sided pain could come either from bony deformity or cartilage damage in the DRUJ, or it could come from a TFCC, which could actually be repairable or degenerated. But what stumps me is patients who have got such a minute discrepancies will continue to complain of pain months and months together. And there are patients, this is my own patient, with a malunited ulna scalloping into the radius, enjoying completely free, pain-free range of movement, and actually stumps me how nature wonderfully heals things. And the ECU, which could give rise to ECU tendinosis and unstable. So all these cases actually make me wonder, how do we really select cases in whom we should really intervene? To summarize, if you apply this 4-leaf clover algorithm, we will come with 4 options for treatment of most DRUJ pathologies. One is repair of the TFCC, as in associated with distal radius fracture or the fresh isolated tears. TFCC reconstructions in the neglected tears. You have a hemi-resection or interposition arthroplasties of the TFCC, or you can do other salvage procedure like DARA or the Sovekapanji. Not to forget that we need to address the other aspects of the clover leaf, the ECU, the bony deformity, and the cartilage defects. Thank you very much.
Thank you, Pankaj.
Yeah, thank you, Pankaj. That was a very interesting talk. Actually, I just wanted to, not about the DRUJ, but I basically did not understand that particular tip which you gave to restore the ulnar sided of the distal and radius by putting a K wire. Can you repeat that?
So I could either play a video if you want. You want me to play that video?
Yeah, I mean, you can just play
I
the video and walk through.
yes,
a
I will
little more
play
in
that
detail.
video quickly. Yes. So what I do is once I find a spike here, what I do is, the reason this spike exists is this plate is fixed only to the distal fragment.
Yeah.
So this plate is fixed only to the distal fragment. There is no fixation in the proximal fragment at all at this moment. So this shaft needs to shift radially, or alternatively, you can say that the plate and the styloid and the distal radius need to shift radially. That's the only way this step is going to go. One of the easiest way to do it is you place a wire into this shaft of the radius, but you don't place it lateral to the plate. You just put it slightly underneath the plate. Once you put the wire underneath the plate and bend the plate over to the ulnar side, it brings out the shaft onto the radial side. Once it has shifted here, and once this shifts here, you put a wire in this hole and fix it there, so that until you now fix your complete you do the rest of the fixation, this should not shift. That's exactly what I've done here. So you can see that was a spike, and this I put a 2 millimeter K wire, not just radial to the plate, but I'm trying to put it slightly underneath the plate on the radial border. And now I bend over this wire. I bend over this wire on that side so that the shaft is now pulled out. You can see how the shaft has now got pulled out here. Now I'll put a wire here and fix it temporarily. Now that's a temporary fixation, and then I can remove the 2 millimeter K wire. Once that is done, and then you put this screw, then you can see that the spike is now completely gone. I think when the spike extends into the DRUJ, we need to be wary of this problem and identify it intraoperatively and address it then and there.
Thank you, Pankaj. I would just want to know, I mean, in case if you find a DRUJ instability, just immobilizing the patient in complete supination, I mean, does that help? I mean, will nature take over and just stabilize the DRUJ, or I mean, we should really be more aggressive and try to stabilize it?
So this is what happens. Some of the TFCCs will heal when you immobilize them in a reduced position for 6 weeks. Problem is, if they don't, then you start the journey all over. Then you investigate, diagnose, repair, and then subject them to further rehabilitation. So if intraoperatively you have diagnosed an instability, then you may not fix it or may not repair it only if you know that it will predictably heal. And as orthopedic surgeons, we all know that bone healing is much more predictable, much more easier to watch for than a soft tissue healing. So if there is a foveal fracture which has fallen back in place, those are the only cases I would say, okay, I would immobilize and watch them, because I can watch for their healing. And if the styloid has fallen in place, I know that the TFCC has assumed its rightful position. If not, I would rather intervene then and there under same anesthesia and be sure of repairing the soft tissue by giving a more predictable healing than wait for another 6 weeks. And remember, in a fracture which we have fixed, many of them intra-articular, if we subject them to 6 weeks of immobilization, we are going to defeat the very principle of intra-articular fracture fixation, which is early mobilization, which and there would be a lot more stiffness of the DRUJ. There would be arthropibrosis of the distal radius. These are realities which many of us do not want to accept. The radiocarpal joint does undergo a lot of arthropibrosis if you immobilize for 6-8 weeks after an intra-articular fracture fixation. So to rid us of this situation, I think it's much better to be aggressive intraoperatively.
So once we have diagnosed a DRUJ subluxation, so you just you just do it arthroscopically, or you just do it open at that time?
So
when it is associated with distal radius fractures.
So I have very low threshold for doing an open TFCC repair. If I have not had a very tiring surgery, then I would attempt an arthroscopy. However, I have absolutely no hesitation in just opening it up. So more often than not, I'll end up doing an open repair. Yes, if I'm doing an isolated TFCC injury without a distal radius fracture, then I would almost always do it arthroscopically.
How useful is Pankaj? How useful is ulnar styloid fracture as a telltale sign?
There is enough return on ulnar style.
Yeah. You say that we just grossly check the instability. That is fine, but that defines the situation. But if it is just an ulnar styloid and you have a doubtful how useful you use that as a telltale sign means.
I would not.
You said you are really tired at the end of fixing radius, then you feel, as Prasad said, okay, leave it in supination and then.
Okay, so I would do the reverse. If in doubt, I would.
What
if in doubt,
as the criteria
I would
that this should. Huh?
Okay.
Pardon?
So if in doubt, I would fix. So there are certain. So ulnar styloid fracture has been contested as being a reliable criterion for DRUJ instability. There are papers which say the size of the fragment does not matter. Whether you fix ulnar styloid or not does not matter. But really, that every paper is perhaps half truth. So if the DRUJ is unstable, then irrespective of the fragment size, I would go ahead and want to repair the TFCC. So I may say that I fixed the styloid, but actually in reality, what I'm doing is a TFCC repair. So if a small styloid fragment still looks off, despite my figure of 8 repair of the TFCC, I'm not too worried because I'm very sure I've done the TFCC repair. So I'm not really looking at the styloid healing or styloid position. Yes, if I see a foveal fracture which has fallen back in place, then I know if I immobilize this would go on to heal predictably, and then I'm happy even leaving it alone. But then I should not hesitate immobilizing it for 6 weeks.
But as you said, there is no role of percutaneous fixation.
I would not. I've seen far too many problems with the ulnar sensory branch of the dorsal sensory branch of the ulnar now to attempt anything percutaneously. I would do open repair.
Okay. Thank you, Pankaj. That was very enlightening. Now I have compiled a few radius fracture cases. Now, as you know, I belong to the category of surgeons who is a general orthopedic surgeon. Distal radius is the most common fracture, and there are so many ways to fix the fracture so much that it becomes sometimes confusing to choose the correct option. So I'm just going to put up a few X-rays, and I just wanted to go through your thought process as to how you people would go ahead thinking about treating this particular fractures. So I'll just share my screen. I would like to thank Dr. David Nelson. During his visit last year, he had interacted with us, taught us so many things, because of which our concepts about distal radius fractures have improved. So this is, once after meeting him now, this is what I've been following. I've been dropping an imaginary line every time I fix a distal radius fracture and see to it that my screws never cross that particular line. So, so this is the first X-ray that I would like to put up. Now, this is a middle-aged gentleman, around 52-year-old, with this kind of injury following a vehicular accident. Now, I would like to know from Dr. Nelson as to what would be our thought process in trying to treat this particular fracture.
Right. And tell me again, this was high energy, I presume?
Yes.
Okay.
Yes, this is high energy but closed.
Okay. obviously you've got a highly comminuted radius and an ulnar fracture. The nice thing about the ulnar fracture is that's going to be pretty easy to plate. You'll be able to get your screws in distally. When I look at the articular surface of the radius, there is an intra-articular fracture, but I think that the displacement looks fairly minor, and I would be very hopeful that this can be fixed quite nicely. You're going to need a long radius plate to bypass that comminution, but this doesn't disturb me too badly. I think it's really useful to get a traction view. When I'm in the emergency room, I would do a traction view here. I try to teach the residents that, and it will show you, does the articular surface stay together as you put it in traction? So my plan on this would be to go to the operating room. I would put finger trap traction on the table. I think you can put finger traps on and just drape them off the end of the table. I put a towel under the rope and above the rope, clip them together, and warn the scrub tech that we can never pull the ropes back onto the table. And that would generally restore anatomy, and I'd get some pictures. Now, I presume finger traps are something that are available to you?
No, we don't use it very often. We just use manual traction most of the time.
Okay. The trouble with manual traction is your assistant now is tied up and can't be an active participant. And for me, I'm operating with only a single assistant, and that assistant has to be handing me the instruments. So I find traction to be useful. Also, it's steady and they don't get tired. So that would bring the radius out. I think I'd put on a volar plate. I'd look at the displacement. I would take the traction off, do the distal ulna. I then check the stability of the DRUJ, and I anticipate how the ulna has broken is probably the DRUJ will be stable, but you want to check it. The scaphoid is a little bit of volar flexion, but I would never at an acute, or hardly ever at acute stage, address scapholunate. I find very often in older patients, there'll be a diastasis, but no pathology. So that'd be my initial approach. How'd you do?
Yeah, I would also want to know the opinion of Dr. Pankaj as to how, what is his thought process when he sees this X-ray?
Yeah, I've been staring at the X-ray. I think the end conclusion, most of us know we are going to plate both these, but it's just so fascinating to look at the X-ray. And as Dr. Nelson pointed out, whenever I see a ulna broken at the metaphysis, I know that the DRUJ is going to be okay. These are the patients who will have fantastic forearm rotations. Their TFCC is intact. The DRUJ will rarely have malunions. I would do exactly as Dr. Nelson said. I use finger trap tractions, same ones which we use for arthroscopy. That frees up one assistant. Very frequently, Dr. Nelson, we are quite fond of external fixators in India, largely because Dr. Joshi popularized it. We call it the GESS, GESS, Joshi's external stabilization system. So we use that fixator, 2 pins in the metacarpal, 2 pins in the radius, and then I hold the length out, Prasad, so that again I operate with only a single assistant at a time. So I use that fixed traction as a length giving device, and I would most certainly do a volar plating, and I would apply a hook plate or a locked 2.4 plate for the ulna. Interesting. This fragment I might just leave alone, or I might put a 2.4 interfragmentary screw just to retain that fragment close to the radius. But I would not hesitate just leaving it alone.
Okay.
All right.
So
Just trying. Yeah, David.
All right. Dr. Chaudhuri, you had said something about it's hard sometimes to pick the right solution. I don't think there's one right solution. The solution is the one that the surgeon is good at, he's confident in, he can do quickly. And if someone wanted to X-fix this, I know for 10 years, I would have placed an external fixator on this. And if the surgeon is more comfortable with an external fixator, you'd get a great result with an external fixator. I cannot get a better result with a volar plate. And it's interesting, when the volar plates first came out, there was a huge controversy comparing external fixation, which is what we were all comfortable with volar plating. And AO had taught us rigid internal fixation and early mobilization, right? I mean, that's a shibboleth we could recite in our sleep. So we were saying, well, if you put on a volar plate, you're going to move them earlier, you get better motion. And we never could prove that. And every study showed they got the same amount of range of motion. And then people started putting on the spanning plate and leaving it on for 3 months. And we all said, oh my goodness, 3 months, they're going to be stiff as heck. And every study of the spanning plate has shown they get the same motion as a volar plate, moving them immediately. I mean, when I do a volar plate, my operating day is Friday. They go to therapy on Monday. So their immobilization is 3 days. And yet 3 months gets the same results. So we have to rethink the arthrofibrosis that AO taught us about. And either the radius is a more forgiving joint or something. I don't know. But anyway, if you're comfortable with a plate, do a plate. If you're comfortable with a spanning plate, do that. If you're comfortable with an X-fix, do that. I think all of them will give you a great result. Just know the details of your technique for an X-fix. Don't stick the pins into the radial sensory nerve. I mean, visualize the nerve, move it out of the way, put your pins in a separate plane. If you're doing a volar plate, know the complications of a volar plate. Keep the screws out of the dorsum, keep it out of the radiocarpal joint, etc. So I think any solution that you're comfortable with and you're fast with is a great solution. As far as the distal ulna, it was interesting. For many years, we always fixed ulnas. And then Jesse Jupiter had a paper in which he said that they don't need to. I think in this high energy state, I would be a little more comfortable putting a plate on the ulna, because it would allow me to be a little more aggressive with my therapy. And one of the things you could say is, this is a patient with a distal radius fracture, or you could say this is a patient with a large soft tissue injury surrounding a distal radius fracture, and the emphasis just on the different things. Given the soft tissue injury, I would be more comfortable in plating the ulna just to be more aggressive on the therapy. But if you didn't, that's okay. Just be aware of that as part of the problem. There are lots of ways to solve this problem that'll give you good results.
So I decided to stage this particular fracture.
No, I just want this one. Can you give me one?
Yes.
Just trying to be a little devil's advocate. Going by AO principles, this is a severe 360-degree combination. Why would you think of only a volar plate? Why not a radial styloid plate also to buttress it on both sides? Hello.
The radius is a very forgiving bone. Healing here is going to be very rapid. I think that a volar plate that's got good fixation probably will support it. I have rarely put on a radial plate. They often have to come out. They often bother the tendons. But if you put on a volar plate and you looked at it and you felt that a radiostyloid plate would give you additional security, do it. It would be the second plate I put on, not the first. They say I do the volar plate first, and if I felt insecure, then I'd do it. But I think I can get a screw into that radial styloid, and I think one screw will often stabilize that. But I've got no objection to a radial styloid plate. I always have one in the room. I think it's a mistake to get in here and then realize you don't have the hardware you need. But let's see how this was managed and
Any
once
role,
it's
any role of
produced, we might
repositioning
get a
the
better idea.
radial, any role of repositioning the radial fragment and then grafting it in the metaphyseal area?
Okay, you were broken up a little bit. Are you asking, would I bone graft this?
Yeah, so repositioning the radial fragment as it has gone medially. So position it with a K-wire and then put a graft, interpose graft there and then volar plate it. Basically, my idea is that you reconstruct the both pillars.
Yeah, I would generally put the volar plate on first and then do the bone grafting. And it's interesting. I've been operating as a surgeon for maybe as long as you have, Professor. And back in the days when we were putting on dorsal plates or external fixators, we would bone graft a lot. And
Yeah.
now that we're doing volar plating, I rarely do bone grafting. And we have to
We
ask
don't do.
ourselves, back in the old days, why did we bone graft? Were we bone grafting because we got non-unions? No. I mean, the only paper I know about distal raised non-unions is the chap in Germany, Prommelsberger, had a paper on it, but he had to gather papers from both Europe and the United States to get his 9 cases. We don't get non-unions. The radius heals beautifully. We were doing the bone grafting to keep soft tissue out, because if you get soft tissue interposition, that's a problem. But with the volar plating, we've not disrupted the dorsal periosteum, and I find that we have to do very little bone grafting. But I think everybody should have a low threshold. If you look at it and you think you want to bone graft it, low cost procedure, almost no complications, do it. But I do the volar plating first, then look at it. I'll bet you get excellent bone-to-bone contact with a little bit of a void, and you put a little bit of graft in. Let's see what happened though. We need a traction view.
Yeah. So I decided to stage this particular thing. So I just put in a fixator. So I thought that once the soft tissue swelling goes down, I would then go in for a definitive fixation by putting in the volar plate. But during the stage when I opened it, it was a very humbling experience that time. I was not able to get in a volar plate. And so I just bone grafted the defect. It was a huge defect. It was very unstable. So I just bone grafted the defect. And I had to abort the surgery at that time. This patient went on to have union, but he's a little painful and stiff too. And so I don't know, I mean, whether what I thought was that I would be able to get a good volar plate, but I was not able to do it at that time.
I think you've done a good job. And I would just say that the hardest thing we have to do as surgeons is go into a surgery with one plan, and the middle of the case decide that that was a bad plan and switch to something else. We tend to have mental inertia. And I would congratulate you on being able to change your plan in the middle of the case. And I think you've done a good job. A traction view would have shown us that this was fairly different than what the plain film showed us. Now, I would say a couple of things. You fixed the wrist in ulnar deviation. We can see that because the lunate is entirely in the lunate facet, as well as the metacarpals are tilted, but I would look at the lunate first. And it'd be nice to fix them in neutral. And I look at your lateral x-ray, and you put on your x-ray, your external fixation from a straight lateral view. And the straight lateral approach is the most dangerous to the radial sensory nerve. And I would tilt the external fixator and come in at a 45-degree angle. So if this is the radius, you want to be up here with your pins, not straight here, but up here. It's safer. But I think that overall, you've really done an appropriate job, and this patient should do well. And it's interesting. The wrist and the elbow are immediately adjacent joints. And on the elbow, if you can't get your elbow all the way out and you can't get your hand to your mouth, you're in trouble. But on the wrist, you don't need to move it. if you've got a good shoulder and good fingers, a stiff radius can still give you a highly functional joint as long as it doesn't hurt. So although I do try for motion, a stiff joint that doesn't hurt should allow this person to earn a living and support their family if it's the person's working or whatever. And I think you've taken a really bad fracture, and I think you've helped them. What do the other experts think?
You would like to add something, Pankaj?
Yeah, Prasad. I was just wondering, when you said patient has stiffness, did you mean stiffness of the fingers?
Case.
Prasad, can you hear me?
Yes. I thought we lost you in between. Yeah.
Yeah. So when you talked that you said the patient has stiffness, can you hear me?
Yeah. Now I can hear you. Yeah.
So when you said patient had stiffness, did you mean stiffness of the wrist, stiffness of rotation, or the stiffness of the fingers?
Patients usually, no, not of the fingers. Usually
of
they
this particular
of
patient,
pronosupination is what he had.
Okay.
He could, yeah.
Perhaps that's where the case for a still definitive fixation of the ulna and perhaps promoting early rotation with the fixator on, there perhaps may be a case for it. Otherwise, the commonest problem, Prasad, that we use fixators a lot. So we know that the commonest problem with the fixators is the stiffness of the fingers, because patients tend not to use the fingers as long as they are under that healing phase. I'm very happy to hear that the fingers are good. I don't think stiff wrist is a big problem.
Yeah. Yes.
And I would agree that finger range of motion is key. The purpose of the wrist is to position the hand where you need it. But if you position a useless hand where you need it, you haven't gotten anything. You got to have good fingers, and you want to encourage them to move their fingers. And if I could throw out a little plea for excellent pain relief. If the patient has excellent pain relief, they'll generally move their fingers, as long as you haven't over distracted them and functionally shortened the flexor tendons. And if they have excellent pain relief, they do well. And one way to do that is a thorough Marcaine block prior to leaving the OR. The doctor being involved with encouraging them to move their fingers. Okay, case 2.
Yeah, and this is the second case. Now, this was again a middle-aged gentleman with fallen outstretched hand. So now, looking at this X-rays, now I would like to know what is usually the plan. Pankaj?
So whenever I see such X-ray, I try to do I give a hematoma block and get a traction X-ray done. If that's not possible, at least intraoperatively, I will see a traction X-ray. So there are a whole lot of things that you read on this X-ray. One, the volar cortex is completely disrupted, so it is a grossly unstable fracture. So this is one fracture which perhaps might require a double plate fixation, volar as well as dorsal. So I would be prepared mentally and place my incisions accordingly. If you see the relationship of the distal radius with the ulna, ulna shaft and the radius are together, whereas the distal fragments have moved out. This indicates that there is going to be a TFCC injury. I'm not sure whether there's an ulnar styloid fracture. If there is, that would substantiate our assumption. But I would say this patient will have a unstable DRUJ post reduction. So my plan for this would be, I would start with volar fixation and be prepared to go dorsally for buttressing the dorsal fragments. Sometimes while I do the volar fixation, I might just temporarily buttress the dorsal fragments with using intrafocal wires until my fixation is done. But if in the end, if I am not happy with the dorsal fragments captured adequately into the screws, and if I find that the carpus appears subluxated dorsally, I would not hesitate opening up dorsally and put 2 more plates dorsally.
Dr. Nelson?
I completely agree with Dr. Andre. That a traction view is going to tell you a lot. You've got a dorsal cortex that's broken off. My initial plan would be it's likely I'll need a dorsal plate, so I just keep that high in my mind and don't let that fall off. There's a significant dorsal tilt of the volar fragment, and the volar plate is going to be probably put in at quite a high angle to reduce that. I would be sure to document in my note the median nerve, because you can see that volar cortex is right up there against the nerve. An interesting factor is this is not the alignment that the patient had at the moment of their injury. At the moment of the injury, those fragments were far more displaced. In my training, which not only was in the previous century, it was in the previous millennium, my chairman told me once of a fluoroscopic view he saw of a patient who had a bilateral pubic ramus fracture, and the patient coughed. And he said the pubic ramus came up to the xiphoid and then came back down. And that was the dramatic proof that at the moment of injury, these fragments are much more displaced. So that volar fragment of the, or the volar shaft of the radius was deep into the median nerve at the moment of injury. And you want to document that. So get a traction view, and then I would start with the volar plate and have a low threshold put on a dorsal plate.
So I decided to treat it with external fixation, and I was able to get a good ligamentotaxis, and I was pretty happy with this kind of fixing. This is a JES fixator, so I was pretty happy with this. Any comments on this particular fixation?
Well, when I look at the lateral view, it looks as if the dorsal and volar fragments are fairly well aligned. This is a good view to show us the whole fixator. This is not a good view to show us the radial fracture. I'd want a much closer view, but I have absolutely no objection to this technique. If this is what you're good at, do it. And these patients for well over a decade, this is the only thing we had, and they did great.
So I just usually, whenever I put the patient in the fixator, I have to observe him very closely. I call him for frequent follow-ups, and I supervise the physiotherapy to see to it that they regain good range of movement together. Pankaj, yes.
Yeah, Prasad, I have a couple of comments. Many times it's how the patient wants to live the 3 months to recovery might dictate the treatment plan. If there are A, B, C options which might give equal outcome at 1 year, it's ultimately there's period to recovery, how the patient wants to live, that decides. If external fixator does give rise to a very predictable outcome in your hands, wonderful. There are a few issues with the external fixators that I have noticed in my practice. One, our climate. It's not easy to maintain an external fixator and a bandage covered in it when we have perennial 80% plus humidity and 35 degrees plus temperature. It's not easy. The use of percutaneous wires in my practice has come down to virtually zero, except in the fingers occasionally, largely because of very high number of infections that I notice. Sometimes they heal uneventfully. Sometimes they have had disastrous effects. So I do not know which ones will have disasters. So I've abandoned them completely. So if you are able to get a predictable outcome, nothing wrong with this really. And if you are comfortable with it and your patients are comfortable with it. It's not easy canning an external fixator in day-to-day life. So it does postpone patients' return to normal life as long as the fixator is on. That's the only concern that I have.
I'd also like to just say that's not a radial styloid pin. Go back. That's a volar pin. Look at the lateral. It's not in the radial styloid. Just be careful. You're right next to the radial artery.
So again, this was the next case. Now, what I'm finding difficult with these kind of fractures is basically the volar. It's very distal. To get screws into that is very difficult. And like Dr. Nelson had said, to put a wire, I'm always scared that if it fragments that particular fragment, then I'm in deep trouble. So now, and most of the patients, sometimes they're covered by these government schemes and they do not allow us to use the volar rim plates. So again, any tips from Dr. Pankaj to take care of these volar rim fractures?
So for for this type of fractures where I see the carpus going dorsally, I would be prepared to put a dorsal buttress plates for this. Of course, and like in previous case, I think the median nerve actually even at this moment of the X-ray might actually be precariously hooked onto that fragment. So I would want to go volar, and if I do not know, Prasad, whether you have seen the presentations on very distal radius fractures which I have made. For such patient, I would put sutures in the short and the long radiolunate ligaments, 2O ethibond sutures, and I use those sutures to get the very distal rim fractures in alignment, and those sutures I anchor to the plate, volar plate. So the volar, that whole construct acts simply as an anchor and not really as a buttress plate, and it has given me very consistent results. Having said that, if at the end of my volar fixation, if I still see the dorsal fragment and the dorsal subluxation of the carpus, I would go dorsally and buttress dorsally. I may not put any screws in the dorsal fragment, but I may just simply buttress them.
Dr. Nelson?
You don't want to have only one tool in your toolbox. You don't want to only have one way of fixing these. But for me, I would actually do a volar plate on this. I don't think it's that distal, because if you look at the lateral view, all you're trying to do is subchondral support. You're not trying to get rigid fixation into that fragment. I think I can get screws underneath that subchondral bone. So my approach would be keep mentally alert. Almost certainly you need a dorsal plate. This is something where I would seriously be thinking about a radial plate. I would get a traction view in the OR. I'll certainly document the median nerve, because that volar shaft of the radius is certainly, I mean, look at how little soft tissue is there. And you look at the shaft and it's right where the median nerve would be. So anyway, I'll do a traction view, get some things, reduce a little bit, get some better views. And I would probably start with a volar plate. Make sure I can't sublux it off dorsally. I had a low instance or low threshold to put on a plate. And I agree with Pankaj that you don't need to put screws in that distal fragment dorsally. You're just going to use that as a buttress. That's all you're trying to do. And that's basically what you're doing on a radial plate as well. So show us what you did.
So I had access, I did not have access to those kind of plates where we have holes distally. So I took sutures. I took sutures with 20 Vicryl, number 1 Vicryl, not ethibond, but Vicryl. And I sutured I put 2 or 3 stitches, and I sutured one of them to the pronator quadratus, and one I put underneath the plate and then sutured it back. So somehow I held the distal rim fracture, and I also did an extensile approach. I removed the vehicle, went in the first compartment, and put in a radial plate also. So any comments?
If you can just go back to the preoperative X-ray.
Yes.
So whenever I see a large radial styloid fragment like this, I know heart in heart that I may have to release the brachioradialis to effect a good reduction. So that was the question that Dr. Sanjay Dar was raising some time ago about the radial styloid not falling back. this is one of those patients in whom despite giving adequate traction and attempted reduction, the radial styloid fragment may still remain out of place. So yes, I would either engage it into the volar plate or use a radial plate the way you have done. Yeah, it looks very good.
So
wait a second, go back. You didn't give me a whack at it.
sorry. Can you
Yeah.
just?
Okay. A couple of things.
Yes.
I think the scaphoid facet is nicely reduced. I'm concerned about the lunate facet. The teardrop is not back where it belongs. So I think that the articular surface is still in a little bit of extension.
Yes.
The images show more of the fingers on the shaft than I need. I would want to get a much closer view. I think the radial styloid plate is probably not out far enough. I think those screws aren't in the fragment, they're in the fracture line. And I would like that plate out a little bit further. The screws are not as subchondral support as I would like. I can see probably a complete diameter of the screw, between the screw and the subchondral bone. And in many cases, you don't have to get it really out far. In this case, you do. I think this case has a significant chance of just a little bit of subsidence dorsally. And I wonder, did you in the operating room try to dorsally sublux the carpus off the radius? Why, or how did you prove to yourself you did not need a dorsal plate?
I usually, like you said, I do not try to sublux the carpus, but usually I put the carpus through the range of the ridge joint through a range of motion, and I see whether there is any particular movement occurring at the fracture site. If I'm convinced that even after moving the wrist through the range of motion a little bit vigorously, if there is, I don't see any movement at the fracture site, I would not try to put a dorsal plate.
Okay, because if you look at the volar plate and that radial screw, I have a hard time convincing myself it's in the bone and not in the fracture line. So I think that the two most distal screws, both of the volar plate and the radial plate, are in fracture lines and not into the fragment. This is a plate that I tell the patient I'm going to be taking out because it's quite prominent. I don't think one can always get the plate so it's not prominent. And I have no objection. I've got a radius I did about 2 weeks ago. I couldn't get the plate perfect. So I told the patient, I think we're going to take your plate out. So those would be my thoughts.
Yes, Pankaj.
Yeah, Prasad, can you just go back to the preoperative X-ray once again? Yeah. So sometimes when I see a very widely displaced dorsal fragment like this, even before I start fixing it volar, I take a small dorsal incision and get the EPL out. There are two reasons for it. Occasionally, I have found that the EPL actually is trapped in the fracture fragment. Now can you go back to the postoperative X-ray? So whenever I see a dorsal fragment which is sitting off the radial shaft with a proximal sharp borders, I just want to be sure that the EPL is out of the harm's way. And it's not uncommon that I've found that the EPL actually there's a spike of bones sitting into the EPL tendon actually. So it just helps to place a centimeter and a half incision and get the EPL out of its compartment, push the fragments back in place even if you don't fix them.
Okay.
It's not at all uncommon for me to do that.
Okay, so now this particular case, I mean, this was a cab driver. He fell asleep while he was driving. So he presented like this. He had been to some other hospital to get a preliminary treatment. So now this is a metaphyseal comminution with the distal radius. He also had, I mean, this was the least of his problem. He had a tibia fracture, tibial plateau fractures. And this was the plates they had access to. These were the longest plates. So, I mean, I don't have the immediate post-op X-ray, but I fixed it. I was not very happy with the fixation. It was very tenuous, but this gentleman presented a few weeks later, around 5 weeks later, with this particular X-ray picture. Now, how could I have improved on this particular fixation? I would like to know, okay, what was the mistakes that I made? Dr. Nelson.
Well, I don't know if I'd say you made mistakes. I'll bet the follow-up was a little bit difficult. Okay. This is a very unstable initial fracture. And if you've got some support on the ulnar side, I think that would help you on the radial side. And you do what you can with the hardware you've got. But this person was moving in the ulna. You can see that the way it's remodeling. So that just meant that there was no support on the ulnar side, and that challenged the radial plate, and you got a non-union. Because this is not a distal radius fracture, which heals in that nice metaphyseal bone. There's a little bit of cortex here. So I think you did a pretty good job. And I think the patient probably didn't help you. And what I do here is I would make sure I've got the appropriate hardware. I would widely debride this. I would send cultures at the same time. I would
sorry, I lost my connection in between. Sorry.
Yeah. And another challenge that you've got is you not only have a radius fracture, that tibia fracture means he's weight bearing on his upper extremity, and that's a strike against you. So I'd revise it the way I said, and just because I wouldn't do a case it's exactly the same way doesn't mean what I did the first time was a mistake. You're allowed to learn. Go ahead.
Pankaj.
Yeah, Prasad, I have, yeah. Can you hear me? Yeah. Can you hear me? Yeah. Prasad, yes. I have a question in earlier case as well, and this why have you been hesitant in fixing the ulna at the same time?
Yeah, good that you asked me. Now my experience is that the most disability that the patient has when he has less pronosupination, when he has restricted pronosupination. So if there is a distal ulnar fracture, then my rationale is that if I get a non-union over there, it becomes a natural Kapanji, and he would get a good pronosupination because of that particular happy accident, if I can say that.
Okay, I mean, I have a objection to that view that we should not be looking at salvage straight away. Salvage is only for bailing out of irreversible positions. So I, as Dr. Nelson said, plating the ulna would have offloaded the radius, which has a long unsupported span. So that would have helped the cause. I would have perhaps put an even longer plate going by the principle of relative stability.
Sorry, Pankaj, 1 second, Pankaj. This was the longest plate.
Yeah, I understand.
Would you have suggested to stack this particular plate?
Sorry.
Stack another plate over it.
No, I don't think so. I don't think the strength of the metal is an issue here. Even 2 plates would have perhaps failed. If I was in any doubt about the strength of the fixation or the length of the plate, I would not allow his forearm rotations to be free. So I would put him in a above elbow slab or a cast until union rather than leave his elbow free, with the hope that the fracture would become gummy, and then I start rotations. So in short, if had to ensure that the bone wins the race, then we should have just immobilized longer, perhaps.
Okay.
One of them
So
had to
now-
fail.
Yes. So now, due to some other reasons, I mean, because we had put him in a spanning fixator for the tibia, he had developed abscess in the thigh and he required some other surgeries for the lower limb. I decided to just go ahead with I just tried to straighten the plate, did a close reduction for this, and I immobilized him in above elbow cast in full supination for a further period of around 4 weeks. And I mean, I was surprised to see that this has gone into union, and the deformity is also not too much. And he, of course, he has some restricted chronosupination right now. So, I mean, this is how because of some other reasons, then I was not able to revise this particular plate. So I just did a close reduction and immobilized him. This went on to night. So,
I think that's a good approach. You've helped this patient.
so do we, Dr. Sanjay,
Yeah.
do we have more time for any more
So ask
cases?
Neeraj. I don't think, but ask him.
Neeraj, are you there?
How many? Actually, this case was operated by me and Prasad together.
I
Wow.
can't.
How many cases more do you have? I thought this was the last case. So we can do one more
Neeraj?
case. One more case. We can do one
Neeraj?
more case. Are you able to hear me?
We hear you.
Yeah, I think there is a network issue with Dr. Prasad. So that actually says that we should not continue any further.
Anyway, I think we can wind up.
Yeah.
Well,
So
this
Dr.
has been,
Nelson,
yes.
so
Well,
would you
this has
like
been a
to
lot of fun, and it's been instructive to see multiple different cases and different approaches. And there's no one right way. There's lots of ways. And just because we wouldn't do it again the identical way doesn't mean the first choice was an error. We're allowed to learn. But this has been a lot of fun. I really enjoy my collegial interaction with surgeons from India. I really enjoyed my trip to Mumbai. I did not enjoy my return to the United States. It took me 2 weeks to recover. But this is really fun to know you and to see your cases and your approaches. And there are lots of different ways of fixing a radius fracture. But thank you for the invitation. This was a lot of fun,
thank you.
even if it was very early on a Saturday morning.
Thank you, Dr. Nelson.
Thank you.
It was wonderful listening to your talk. Thank you.
Thank
Thank you,
you.
Dr.
Thank you very much. Bye bye.
Thank you, Pankaj. Thank you.